For the premature ejaculation, in summary, it said the longer duration diabetes was significantly higher. Higher physical activity was found to be protective. Behavior and behavior, that means the behavior and education factors may influence the symptoms of reporting and the risk. These findings support a broader lifestyle-focused diabetes care. What about the index for the erectile function domains? These were 5 domains. We have the erectile function, which you see the median for this study population was 19 with a minimum of between 1 and. So despite a lower prevalence, ED remains clinically relevant and should be actively screened for. So doesn't mean because we have said it's not as common, we should not be screening for it. We have tools for that. What about the factors that are associated with ED? Age was initially significant without the adjusted values, but that was lost. Then high physical activity, again protective. BMI, initially on the adjusted odds ratio, it was significant, but it was lost for significant. Then duration of diabetes remains significant for both adjusted and unadjusted odds ratios. So what are the factors? So longer duration, higher physical activity, protective, and the clinical risk may be influenced by vascular, metabolic, neuropathic, and physiological assessment. So it appears that PE is more prevalent than ED in this study population. Physical activity is more protective. So we need integrated sexual health assessment, diabetes care. Then sexual function, dysfunction should be addressed proactively rather than waiting for the spontaneous disclosure by the patient. Clinical implication, validated tools are there. We incorporate sexual dysfunction in men, promote healthy lifestyle, adopt multidisciplinary between physician, neurologists, psychologists, and educators. By study limitation, this being a cross-section study, potential of underreporting, we cannot generalize this study. And because these are self-reported, they could be influenced by recall bias and social desirability. Take-home messages for this study 1. Sexual dysfunction is clinically important and under-recognized complication. Same study design, it was multi-sectional. This post-study population had 421 men. The tool that we used for this study was the Female Sexual Function Index. These are validated 19-item self-reported questionnaire. And there are 5 domains that were assessed. There was desire, arousal, lubrication, orgasm, and pain. Additional data, we picked retrospective extraction for relevant clinical data from the patient's record. The study variables, the FSFI index score of less than 26 was shown that this showed the patient has a sexual dysfunction. For the independent variables, these are the factors that we assess, and the data analysis was similar to what we did for the men population. So these are the results. The mean age was 51, majority had type 2 diabetes, majority were employed, majority were married, and 50 were postmenopausal. It was an obese population with mean BMI of 31%. So the prevalence is quite high as you compare with the male. It was about 76%. And as you can see, if you be able to interpret this, then if you look at the first column, the scores of 3, the desire had the lowest score, and you see the cutoff is less than 4.2, and the arousal. Those are the 2 challenges that most of our women had. And we are expecting for the diabetics to have more of the pain, but surprisingly, this study population, the pain was not a main concern for this study population. But you can see the ranges are quite variable. You can see the first one between 5.4. So there's a lot of variability for this score. So you can see is what the desire and the arousal were the main concern for the female with sexual dysfunction.